Welcome. My name is Sherry Cisneros. If you don't know me, I am the Navigator Program Director here for California Bridge, and I'm in charge of all things Navigator training. It is always near and dear to my heart because I know we tailor make these for the feedback that we get from you guys and your questions and things that you want to see. So always remember, fill out an evaluation. You're going to be sent that via email after this session, and put down there what you guys like, what you want to come to, because we can tailor make it to what you need. Again, today, thank you for joining us for Overdose, Confidentiality, and Ethics. As you know, we share all of our materials. We are a part of Public Health Institute, and so we will share the slide and the presentation in that post-event email. Have nothing to disclose. We're all things CA Bridge. And we just want to make sure that if you are chatting, because we do ask questions, we love engagement. If you don't know California Bridge, that's one of the things we pride ourselves is to engage with our audience. But please make sure that your question is addressed to everyone, okay? Because if you only address it to the panel, nobody knows what you're asking, and somebody might want to know that answer or the question. So definitely make sure it is everyone. And let me see. Let's move on. CA Bridge, if you don't know who we are, who are we? Well, we provide technical assistance, and our goal for California and California Bridge is 24 access to high quality treatment of all substance use disorders in all California hospitals by 2025. We achieved, I want to say not 100%. Definitely, we've reached out to over 280 hospitals out of 330. So we like that number because, our goal was very high. However, we're almost in the over 80%, more like almost 90% of hospitals that engaged with us to promote medication for addiction treatment in the hospital emergency rooms. You guys know me, I always like to just review our California Bridge model. This is the basic of our MAT programs in all our emergency rooms. Number one, low barrier treatment. That is your hospital emergency room providers giving buprenorphine without labs, without urinalysis, without all of those things that make the visit very high barrier. We switch to low barrier. Patient comes in and says, hey, I'm going through withdrawal. Who better to listen to that a patient knows their own symptoms? So our docs are giving low barrier buprenorphine treatment in the emergency room for opioid use disorder. And then the second two parts are my favorite because that involves you as a navigator connecting to care and harm reduction. You guys just blow my minds away with the stories and all of these great patient outcomes, and that you exceed expectations. And we know that this role is so crucial for positive patient outcomes. So we thank you. We have some announcements, and we just wanted to let you know we have our Navigator update. That's once a month. And these are 30-minute discussions. Latoya, our project manager, is in charge. And these are great updates on just what's going on in trending, as well as useful information. Our next Navigator Focus series will be about co-occurring disorders, mental health, and substance use. So please join us. We have a great speaker coming about new treatments. So it's always great to come to that. We also have our July Navigator Spotlights. We've started spotlighting some exceptional navigators, and believe me, it's so hard. It's so hard because all of you are doing outstanding jobs. So, definitely keep tuned. But for July, we have Jeffrey, Stephanie, Nazareth, as well as Tambra and Angela. So congratulations to you all. Today, these are our objectives. If you are here for CEUs for CADAP or CCAP, these are the objectives. And I want to take a moment to prevent, remember, honor, support for the over 100,000 lives lost to overdose. We know that almost 75% is attributed to fentanyl. So just take a 5-second stop and pause to remember. Thank you. For those, if you're planning an event for International Overdose Awareness Day, don't forget to post on Slack or send us a picture. We really want to promote awareness. Thank you. To get started, I wanted to just kind of review our overdose facts and where we are at the present time. I wanted to show you that after many years of doing this, if you look even prior of California Bridge existence in 2018, this curve for overdose deaths has continued to increase. If you notice from 2019 when CA Bridge came on until now, January 2024, if you notice, what is this? Not only did it level, it dropped, you guys. So this is the first year in many, many years that it has dropped. We have seen a change in the overdose curve. Significantly, it's a 7.5 change nationally. So what you're doing works, what you do matters. You know, for so long, it seemed like an unreachable goal. And I'm so proud to report that there has been a change. So, okay, so that's the nation, but what's going on in California? Well, we have received almost a 3% decrease. So again, we're making strides, and this was not overnight that these overdose rates went up. You've seen many, many years. So again, we are making change. You are doing great things out there, you guys. So just wanted to share that about the overdose rates that are going on. And here at California Bridge, we were always want to raise awareness about access to care for people of color. And we want to make sure that you guys know here on this overdose rates by race that American Indian and Alaska Native continue to increase as well as Black. There has been, and the people of color. So again, always be aware of access to care and to really promote awareness and increase that access to care for our vulnerable populations. Well, our first speaker today here is one of your favorites. You guys know her, Chaya Vang, and she's going to talk to us today about overdose awareness and prevention. Chaya, take it away.
Hi, everyone. Good morning. My voice echoing, or is it Sherry that was echoing? Okay, I hope I'm not echoing. Well, hello. I just want to add a little bit to what Sherry kind of went over with the overdose death rates. As many of you still know, I am still here at Fresno Community Hospital as a navigator too. And in Fresno County here, we have definitely seen a decrease in overdose death rates. From 2021, we had about 114, and that has slowly decreased. The last year there was 94, so it did go down a little bit to by 20 deaths, which is great. And it is a slow number, but it's going. And I also want to share about a recent community outreach event that I did. We're at a booth, and a very young girl that looks very young, much less than 18 years old, came up to me and just thanked me for giving out naloxone. And of course, I asked her, "Oh, do you know what naloxone is for?" And we're in this public park here. This girl, she's holding a little boy's hand too. She had tears like come up in her eyes, and she just poured out her story about being an addict to drugs 4 years ago, overdosing so many times, so much more than she can count. And although I have never personally had an encounter with her, she shared that she was so grateful just being alive and seeing the small change in stigma and how the resources that have become available in the last few years. She didn't know where to go get the naloxone, neither before they go even get help. But she offered something great. She asked if she could come speak at like anything we have if we ever need a testimonial. Um, and I was just kind of left speechless and very inspired by this very young girl that I did not know at all, that she wants to even spread awareness because she knows that this is her community and this is a problem. So I'm sure many of you navigators out there have had similar encounters like this before, and definitely this is what we do, right? Giving hope to people. So today I am going to go over overdose awareness and prevention. If a question comes up, please feel free to type it in the chat, and I will do my best to keep my eyes on the chat too. So we'll go from there. All right, so prevention is knowing who are the people that are high risk for overdose. And these are some examples only. People who have recently overdosed, any patients who have relapsed after detox for being in an inpatient program, anyone taking illicit or injecting drugs, anyone on opiates, recently incarcerated, or adults ages 18 to 54 have definitely shown a big increase in overdose, which is going to be shown in the next slide. So this bar graph right here is from CDC, and it shows the rate of overdose deaths by selected age groups at 15 years and older in the United States from 2021, which is the navy, and then the 2022, which is the kiwi color. Two of the highest age groups here are right here in the middle of the chart, 35 years to 54 years old. And so for what I am seeing in my hospital, just in the last year, there's definitely been an increase in overdose for patients on prescription drugs, which does fall into this age group, and definitely an increase in younger patients under 24. And then this study here is on patients treated in a Massachusetts emergency department for opioid overdose from the years 2021 to 2015. And just take a moment to look at this chart and see what stands out to you. I am surprised and super stunned because when I was studying this chart, the number of deaths after the ED visits for non-fatal overdose, so someone who survived an overdose, is super high after the first day of overdose discharge, the first day of discharge compared to the rest of the month from being discharged from the hospital. So to me, the biggest takeaway from this study is that post-overdose patients are some of our most vulnerable patients. Next slide. And then, so what is your role as a navigator? Because being a navigator is so vital in overdose. You are someone that can provide non-judgmental support to the patients. You can advocate for buprenorphine to any patient who uses opiates, especially if they're experiencing withdrawal. And then maintain confidentiality and express that to the patients, so that way you can build rapport with them, because we know that takes time, especially with the population that we serve. And then definitely just educate your patients, their families, and their friends. And then you can also provide harm reduction resources such as naloxone and yourself as a contact. Let me know in the chat, is there anything else you may have incorporated into your role for patients that overdose? And we can go on to the next slide. I don't see anything, so I'll definitely go on to that. So many of you may be already doing this without even formally calling it a safety plan overdose. And this is just a suggestion. Consider having some kind of plan for your patients if they come in as an overdose. So first off, let me know if anyone here has a formal, what we call a formal overdose safety plan that has been placed and been and placed. So first off, you want to educate the patient and the family about the high risk for overdose. You want to provide harm reduction strategies, even if they're just not ready to stop using or they say this is the only time it's an accident. Always just tell them start off with a small test dose and much less than their normal dose, and then slowly manage their use slowly, as slow as possible. Use go to the same supplier if they can, and then definitely always use with a friend. Take turns and have naloxone at hand. That way, if something does happen, the one person can use the naloxone. And you can, as a navigator, can also provide the naloxone test kit, naloxone kits and the fentanyl test kits at discharge. So if your site is not already distributing either one, definitely reach out to us so that way we can help guide you along the way for that. Make sure you have a contact number that you can give to your patients. So that way they can reach you if they need help. And then refer to your local resources and the 988 number. And then remember about the chart I talked about with the high mortality risk post-discharge. Make sure that you can do a follow-up call if you have a phone number for that patient, because they need, sometimes they just need a little bit of check-in and hand-holding. So like I said, we know that all hospitals have different policies and procedures. So again, these are just suggestions that can be implemented into your role. Next slide. I haven't seen anything in the chat yet, so I'm gonna just keep going, okay? So who is at risk of witnessing an overdose? Family, friends, anyone who gives shelter to an opiate-dependent person or who use drugs with them. And then people who work with high-risk patients or clients. Almost every month here, we have local shelters that reach out to us for naloxone each time they have an overdose or a new staff comes in. So they do know that about naloxone, you know. And then again, everyone, even you, me, all of us, we can witness an overdose anytime without even thinking about it. So I'm going to read this quote right here. Roughly 1 in 100 overdoses is fatal among opiate-dependent people. Within their lifetimes, almost half will personally experience one non-fatal overdose, and about 2/3 will witness someone else overdose. All right, go on. We can go on. And then now we're going to go over some harm reduction for overdose. So one thing we can provide and advocate for is naloxone, right? Remind your patients to take action and use naloxone to reverse an overdose. And also know and share this information with your patients. That naloxone is an opiate antagonist. It is short acting, only lasts about 20 to 30 minutes. There are things to consider for safety, such as it can be administered to everyone except newborns, so someone less than a month old. And all high-risk patients should be given naloxone at discharge due to fentanyl contamination in substances or just being near anyone who may be at risk. Next slide. So we want to highlight a milestone that we have achieved. So we have estimated about 300,000 naloxone kits distributed across California emergency department. So someone throw some confetti here, because this is great. This is how we are slowly decreasing these overdoses. Next slide. Okay, so another tool is fentanyl test kits. So offering the fentanyl test kits to patients allow for them to test their substance before use. The fentanyl tests do not indicate how much fentanyl is in a batch. It does only test for the presence of fentanyl. And then you can apply for a free supply of fentanyl test strips through DHCS using the same application for the naloxone. And just remember, this is just to keep our patients safe. So I want to know who here has received their free fentanyl test strips. Denise has. Oh, great. Geneve, yes, you did. All right, thank you. Hi, Sia. I see quite a few coming in, so thank you. I know you guys are still listening to me. So it is important to know, I'll go ahead and go on to the next slide. It's important to know about the test kit itself. I do recommend that if you can, when you get it, like read it, learn about the packaging. This is what this package right here on the slide is the test kit that comes from DHCS. The brand is Dose Test. On the left side, you'll see inside there's a little plastic scoop to help measure the substance. And then there are printed numbers for the amount of water that is needed to test. It does not come with the water. There is a QR code that is used. You can scan it to report any positive results. And then there's also an expiration date right there. In the middle section, you will see that there are instructions laid out in 6 steps. And then also how to read the results on the strip. The testing strip is inside this little section, this big section actually. And then on the right side, there is, if you open it up, there is a little paper guide in there with information on the kit itself. It talks about what fentanyl is, the importance of testing, how to prepare different forms of substances, such as IV, liquid, and herbs, and some safety tips are in there. And it also tells you how to dry the tested sample. So remember and remind your patients too that the fentanyl test strips are not for use inside the hospital. Give it to your patients to go test their supply outside of the hospital. And if you want more information on these test kits, you can definitely use this link here that will be sent out after the presentation. It's provided by DHCS. Next slide. And then, so if you have not heard of this, we want to share this resource here. It's called Never Use Alone. It is a free 24/7 hotline that patients or anyone can access to have someone stay with them while they are using. They do have to give their name, the location where they're at, and a phone number that will only be used if needed to notify 911. So if the patient becomes unresponsive, the operator will call 911. Definitely if they're using with friends, everyone should have naloxone in case ever needed to do a reversal. But if they're using alone, this line here is a very good, safe alternative option. And something I learned when I was just working on this slide is that there's a Spanish line that they could use for Never Use Alone too. So it is 2 separate numbers, and we will share that out when we do the follow-up email. Next slide. Okay, and then so these are some of the resources for overdose. California Bridge has a harm reduction, a guide to harm reduction in the emergency department. Definitely share that with your team. There's a 988 suicide and crisis lifeline that can be called or text to. And then harm reduction coalitions, find out what is local to you. In the there's also the California Department of Public Health, CDPH. There's DHCS, free naloxone distribution, and the fentanyl test kits that I keep talking about. And then there's the California's Overdose Surveillance Dashboard to see what is happening in your area. So we would love to know what other resources you have used for overdose harm reduction, let us know that in the chat. And before I completely hand it over, if you have any questions, please drop it in the chat right now. I will look at it real quick. Does anyone know if like restaurants, corner stores, and bars are able to apply for the Narcan through the NDP? We have to get back to you, John. If you go on the DHCS application, it does tell you who can apply. It breaks it down to like the different organizations and what is needed from each organization to apply for the test kits. But we can definitely look into that for you.
And John, I can just add to that. It's right now, restaurants and bars cannot apply, but you can supply. You can supply them. I know a lot of navigators supply a lot of local little businesses, and I mean, you know, at Pomona, I give some to our police department. So there's no stipulation. If you have Narcan, you can give it to them as well. So, but right now they do not. There has to be a standing order. It's a process. So definitely, you know, more to come, and look on their website. That's the most, like Chaya said, that's the most updated information is the DHCS naloxone distribution project.
I'm not gonna tell you guys who it is, but we have a navigator that told us that she gave out naloxone to the gas stations in her area and they love it. So I'll wait for her to share that when she's ready. But I'm going to see, there's no more questions. I'm going to pass the mic to our fabulous onboarding specialist, Latoya Mitchell. Thank you, everyone. Bye.
Hi, hello. Okay, so hopefully you gained a lot of insight from everything that Chaya went over with you know, overdose awareness and such. I will be talking with you about confidentiality. So next slide. Okay, HIPAA. So what is HIPAA? HIPAA is the it stands for Health Insurance Portability and Accountability Act. It is a federal regulation, and the purpose of HIPAA is to protect patient health information. The forms of patient health information covered under HIPAA include physical, electronic, and oral disclosures by covered entities. So covered entities could be your, you know, various treatment centers and organizations, things like that. Anyone that gets, it's federally funded. HIPAA also allows for the use and disclosures of patient health information for the purpose of treatment, for payment, and for healthcare operations. Next slide. 42 CFR Part 2, or just Part 2 to make it so much easier, everybody recognizes it as Part 2, is the Code of Federal Regulations, meaning that it is a federal regulation just like HIPAA is. The purpose of Part 2 is to reduce stigma surrounding substance use disorder treatment for the records and for the to protect the patient health information. And so it does that through these regulations. Part 2 also includes physical, electronic, and oral patient health information, again, just like HIPAA does, but it's specific to information that's related to the substance use treatment. So that's where the two differ a little bit. Part 2 also requires explicit written consent from the patient in order to disclose SUD treatment records or any of the patient health information. So always remember that difference between HIPAA and Part 2 is for anything related to SUD treatment has to be written consent. So there are exceptions to this, of course, which is some of what we're talking about today. So if you have questions, make sure to check with your hospital and review the sourced material that we're going to send out in our post-event email. Next slide. Okay, so there have been some updates to the 42 CFR Part 2 regulations. To sum it all up, a lot of changes came both through and after the pandemic of 2020 pretty much. And so the main things that you want to know is that in this year, in March of 2024, HIPAA and Part 2 regulations were changed so that they could better align with each other. So what does that mean for you? What that means is that a signed consent allows for future uses and disclosures, again, for the purpose of treatment payment and healthcare operations, also known as TPO. You'll no longer need specific names or entities listed on the consent. It can be a kind of grouped statement or groups of people listed. You don't need to say specifically to, this consent allows LaToya Mitchell to receive my information. It could say this, consent allows my treatment team to receive my information, or healthcare plans as the recipients to receive the information. So that's a pretty cool change. And then all of these changes and alignment of Part 2 and HIPAA really allow for better follow-up. So when when our navigators are trying to navigate patients from the hospital setting, it will be much easier to coordinate that information for the continuity of care for the patient and be able to share information essentially back and forth and follow up and see how things are going. Check and see if patient made their appointment, things like that. It's no longer going to be as difficult to kind of get that follow-up information. So there are a lot of nuances with that. So again, I really encourage you to talk with your hospital leadership to, make sure that you're following whatever guidelines your hospital is giving you. If you're at a treatment center, same thing, follow whatever your leadership is, saying to do. And then, so by April 16th of, by February 16th of 2026, all entities who provide treatment for SUD, I believe it also includes referrals, will have to comply and basically, set up their systems to comply with these changes. And so for the question in the chat, for the sake of time, I will not go over examples quite yet, but we will for sure provide you with the updated fact sheet about these changes that align Part 2 and HIPAA in our post-event email. Okay, next slide. So we've talked quite a bit just now about disclosures. And so we want to always be very cognizant and aware of what disclosures are okay and which ones may not be. And so one of the important ones to kind of discuss is going to be post-overdose disclosures. So if you can type in the chat when you have a loved one present in the room post overdose or a friend, how do you handle that? And so I guess in the chat you can simply say, do you disclose to the patient and talk to them freely, or do you ask them about is it okay to talk about this in front of this person? So typically, yeah, absolutely. Always ask, and it doesn't hurt to ask. Whereas it could potentially cause some ripples if you don't ask. So typically you'll want to talk with the patient about it, and you'll want to ensure that they're comfortable discussing about their overdose, what happened, their substance use, all that good stuff in front of that person. So definitely always ask and get permission first. Sometimes even introducing yourself as the substance use navigator can cause situations where the person there is like, wait a minute, like what? Substance use, what? So keep that in mind too. Okay, so when you have a next of kin and emergency contact listed, what constitute or who constitutes next of kin? Go ahead and drop that in the chat. Who constitutes next of kin? Who should be contacted first? Should it be the next of kin or the emergency contact? All right. So I see emergency contact. That makes sense because if it is in the case of an emergency, you typically want to contact the emergency contact. Sometimes the emergency contact and the next of kin are the same person. Sometimes they're not. But the main thing that I want you to take away from this conversation today is that the person you would contact would be whoever is the patient advocate. So who is the person that advocates on behalf of the patient? Who is the person that knows and understands what it is that the patient wants? So that can depend. It can be the next of kin. It can be the emergency contact. It might even be somebody different that's not listed. Maybe they haven't updated their paperwork in a while. So always keep in mind who is the patient advocate. And so that's the next question. I just kind of said that it could be the next of kin, it could be emergency contact, it could be somebody not listed there. But again, the most important thing to know here is that the patient advocate is the person who's going to carry out the patient's wishes and do whatever is in the best interest of the patient. So you don't want somebody who's going to decide on their own to go against patient wishes. That's not advocating for what the patient may want. And sometimes that patient advocate might be the navigator. So you might be in a position of advocating on behalf of what's in the best interest of the patient, obviously with the patient's consent, and they've stated what it is that they what they want. And yes, I agree very much, Tambra. Next of kin does not mean they have a relationship with them, which is why, but also same thing for emergency contact. Emergency contact, they may not have an actual relationship with them, or they may. So it's whoever is the person that's going to truly carry out the wishes of the patient, and advocate for their best interest. Okay, so another thing is that as a navigator, there might be some pushback sometimes, and you might be caught in the middle a little bit. So this is a reminder for you to, if you're a navigator, a social worker, even a counselor, if you are advocating on behalf of the patient, identify yourself as such. You'll want to say, like, I'm advocating for the patient. I am the patient advocate. They stated this, they want this. And kind of stick to that fact of you're advocating for what the patient wants, not what other people want. And that can get a little bit difficult. So also another thing about the patient advocate is this could be somebody not related to them but who it can and cannot be, may or may not be related to them, but it's the person who is gonna, who maybe is taking them to their doctor appointments, the person who helps them, get their medications filled. It could be the mom, the best friend, a significant other. It could be any sort of relationship. It could be the pastor. But keep in mind that it's the person who's going to advocate for the patient. Next slide. So, when we're talking about maintaining confidentiality, we want to consider some of the other scenarios that we might encounter. And so, it's always a very interesting question to ponder. How do you maintain confidentiality when the patient can't speak? So if you guys can, in the chat, let me know, what would you do if the patient can't speak? How do you maintain confidentiality? It's complicated. So what I'm going to say is that, say that there's a patient post-overdose. Patient's not alert, but the vitals are stable. And say that the hospital staff calls the emergency contact. This is a situation where you would ask yourself, is this part of HIPAA? What additional information might you need in order to, figure out whether there is an appropriate disclosure of information? You might also want to find out what other substances or details are involved. Yes. So I see in the chat, there are definitely different ways to communicate with a patient. And especially if you have a patient who is nonverbal. I'm considering more along the lines of when an overdose happens. A lot of times post-overdose, emergency contact is contacted, or sometimes whoever's listed as next of kin. So it's important to be mindful of, again, is this part of HIPAA? Is this a situation where the information is needed to be disclosed? Patient is stable. So factor in all of the details, so that you can always be mindful of whether or not the information needs to be disclosed. That is a very good point, John. Thank you very much. So in situations where the patient cannot engage, you get the social worker involved and allow them to kind of take the lead for contacting other people and providers for collateral. You might also reach out and ask what they know about the patient, about the medications, if they're on Suboxone, methadone, etc. Absolutely. And yes, Thank you very much, Alicia. So the standards for care are always very important and definitely need to be followed if a patient comes in post overdose and cannot speak for themselves. They may not want their emergency contact knowing that they just overdosed. I know I've had that situation in the past. So again, something that you'll want to keep in mind. So say you helped a patient with a referral and a couple of days later, they call to double check about their appointment information. Is that an acceptable disclosure? You can type yes or no in the chat. So patient was discharged from the hospital with a referral. 2 days later, they call and they want to find out if their appointment time is correct or what their appointment is, day and time. All right. I would say probably some of the majority here feel that this is an acceptable disclosure. Absolutely. So when the patient themselves call, it's perfectly okay to give them their appointment information, right? So now let's say that the mom is calling because she helps patient coordinate their appointments, transportation. She helps make sure that they get their prescription filled and that it's paid for and that it's available for them to take. So is it an appropriate and acceptable disclosure to give that information to mom? All right. So mom is the patient advocate. So we just talked about what HIPAA allows and when it's for the treatment coordination, payment, and healthcare operations, it is covered. So mom can absolutely receive that information as the patient advocate. She is the one helping to ensure that patients' wants in regards to treatment are being carried out. So totally appropriate disclosure there. So many of these questions can overlap into ethics. So thank you all for engaging with me and humoring me as I talk about, HIPAA and 42 CFR Part 2, disclosures and confidentiality and all that good stuff. And so now we'll hear about ethics from Sherry.
Hello. Hello. Now we're going to talk about ethics. That was a great job, Chaya and Latoya, and thank you for engaging in the chat. That was really great. I love all the answers, and I really encourage you to find out how you can identify a patient over the phone. Every hospital must have 2 patient identifiers. What is that for your hospital? Specifically over the phone, yes, you can give information. So please verify what you can do. Normally, it's name and date of birth. And you can give information over the phone. So if you don't know, it's a good time. Take the opportunity to find out if somebody calls and requesting information. And if they want to even a copy of their records, do you know how to assist them with that? So those are very important things. Moving on, we want to just review some best practices for ethical situations. And one is always ask for permission, consent, and document. So a lot of you had a lot of great answers, and they were all really good. Always remember, it can be verbal, and I like that somebody put that in the chat. It can be verbal. It doesn't have to be written. And as long as you document that the patient gave you verbal consent over the phone to discuss the plan of care or discuss the follow-up care with their mother, with their patient advocate, that that is something everybody should do. So always make sure you're you're documenting that actual verbal consent. I do a lot of this because I'm still on staff and I do telehealth. And so basically it's verbal consent to refer to, speak to, and I'm glad I'm talking about, Latoya's updating because I write the specific person. So now I can just put the treatment team at wherever I'm sending it. So I love that. But always, always ask for permission, consent. And when going into a room, as Latoya said, if there's a room full, it may be, hey, can I have, just a minute of your time? Who's in the room? I'm Sherry. I work for the hospital. I'm here to talk to you. Do you mind having a conversation? Or sometimes it's too much in the room, specifically if, you're uncomfortable, right, with your patient. You can say, hey, why don't you guys take a break? I need to ask some personal questions. Always make it light. The patient's there and, they've had a crisis event. So again, those are just some tips. For complex cases, and a lot of you gave this answer, ask for help from the healthcare team. Always refer to the nurse in charge or the social worker. You are not alone, especially with complex cases. This may be above your scope of practice. They may ask you for help, such as, hey, this patient goes to the treatment center for methadone. Can you help us with that and find his information? Definitely, you can always help and support, but really, make sure it's a team effort, you guys. You are not in this alone. Know your hospital policies. And this is a great reminder. Like I said, take the time to find out what patient identifiers you need to talk to a patient. But also know your hospital policies about adults and minors. Okay, if you take care of minors, what's those requirements? Legal holds. We did not talk about 5150 or 1799, but make sure you know what that means. Legal requirements, Latoya went over today. Accepting consulting on patients you personally know. Can you take care of your cousin, your best friend? Can you consult on those patients that you personally know and have a relationship? That's something that's is very much an ethical dilemma. Okay, in most hospitals and facilities, you cannot take care of somebody you personally know. That is against a policy. So make sure you know about your policies in your hospital. And then reporting requirements, right? Are you a designated person to report? So there are some in the hospital, and so know your scope of practice and follow your scope of practice. We do not want anybody to be left in a position that you weren't aware of. I wasn't supposed to, I was. And with any question, let us know. We have so much in this room right now. Let me look. We have so many great navigators with so many great advice. You guys are putting it on the chat. We have approximately 71 people in this room. You have a team behind you. So please do not think you're alone. There's always somebody on Slack. Shoot us an email. We never want you to think that, wow, I'm kind of an island out here. I don't, just run it by somebody. Because even getting it out, your stress level will go down. As soon as you kind of verbalize and say, okay, now, or talking to somebody, it kind of helps. So always make sure you know that you have a team. All righty. We have some case studies, but I think Latoya did a great job. We have a few minutes left, so we might only be able to get through one. This is a patient, Andrew. He's 35 years old, brought in by ambulance and found unresponsive. So this was that patient that can't speak, right? Patient given a naloxone in the field by a bystander with good response. His past history of substance use and suicidal ideation states he has not used heroin for 8 years and is taking his psychiatric medication. Patient requests his medical, now he's up, right? He's in the hospital. Patient requests his medical information not be given to anyone and gets upset when the navigator arrives and announces their title in front of visitors. Remember, what is it that you're saying in the room in front of visitors? Significant other approaches you and asks about the drugs that were found in his system and that they are the next of kin and that he will be taking the patient home. They had a serious fight and he needs to know if he's mentally unstable or if it was drug use. What are your thoughts about this patient, you guys? I know we have a great team to share your thoughts. Definitely, I feel there's lots of information here. The question that I have is, can we give this significant other the drug tox screen if one was taken? Is that something that you can do or willing to help him? Type it in the chat. All right, I'm glad. No, we're not going to tell him. Okay, but I'm going to push back. Okay, what if he is emergency next of kin? He lives with the patient and he doesn't want to take him home if he's mentally unstable or if it was just a recreational use, right? This is one of those patients. Remember Chaya, start low, go slow. Well, he's been 8 years sobriety. So what would you think? Okay, Amber, I love that. Always encourage them to have a conversation with their loved one. If they press it, I refer to the attending physician. Excellent, Amber. I think that's a great answer to all of this is, and Artini says, I work for the patient. Excellent. I know some of our significant others, families, mothers, friends, they've become very assertive and aggressive. And, you know, it's understandable. It is their loved one. Tammy said, still can't disclose, but have individual disclose to significant other. I think that's a great way is, you know, we have the time to talk to both parties and kind of bring them together and be a mediator. You didn't know when you were a navigator, you're going to be a mediator, right? And kind of guide them with, you know, this patient will need some aftercare possibly. So, you know, at least you have somebody to talk with. So definitely, I love the answers. I love the engagement, you guys. This is great. So he disclosed he's drug use with, he has not disclosed. He has prior mental health hospitalizations, states he wants to leave AMA. Then you make so he goes home, he left AMA and you make a follow-up call and a woman answers phone, says, tell me what happened. I am his mother. Okay, I know this has happened to you guys. Patient leaves AMA. Are you guys following up on those AMA calls when a patient leaves and it's substance use? I want to hear from you. Type it in the chat. I know this is happening. Okay, no, you're not. You guys are not following up. Okay. Yes, I follow up. Okay. Follow up, but only leave name and number and don't disclose. Speak to patient only. Okay, perfect. No. Okay. All right, guys. So that's our case studies. Again, we just like to review and hear from you. Any other questions? This has been, time goes by so fast with you guys. I wish we could be longer, but these are an hour and we know you're actively working out in the field. So definitely, you know, if you have a question, you can put it on Slack, email us at mentors@cabridge.org. Anything else, you guys, before we leave? I don't see any questions. We're going to move on. There are some takeaways. You always use best practices for confidentiality, ask healthcare team for support, protect the patient's well-being. And you guys already know this. It can be, and ethical decisions, it can be difficult due to your personal beliefs and biases. Remember, you are the patient advocate, as others put that in the chat. Know your hospital policies for everything. And when analyzing ethical dilemmas, always maintain your professional boundaries. So always good to take. Here's our resource page. If you need any access to our Bridge Academy with webinars and trainings, please use the QR code and contact us, mentors@cabridge.org. I have enjoyed meeting with you and our speakers. Thank you, Latoya and Chaya. And, send us your pictures and what you've done for International Overdose Awareness Day. This is your time to shine. So I really hope you take the opportunities. Thank you for joining us, and we will see you next time. Have a great day, guys.